Hi, I'm Dr. Asghar Husain, orthopedic surgeon. Welcome to the first episode of Surgical Theater. I've had a lot of questions and comments on what the details of surgeries actually are. So instead of telling you, I'm going to show you. I'm going to bring you into an operating room and I'm going to show you step by step how we get some of these surgeries done. And so on today's episode...
Wait. You know what would be an interesting idea? Because it's surgical theater, right?
Can I at least just finish the introduction?
Hold on. This is a great idea. You're gonna love this. Surgical theater. So surgical theater reminds me of Masterpiece Theater, an old English show where they have the guy, Alistair, whatever his name was.
I don't think anybody knows what Masterpiece Theater is.
It's like this old English guy, and he'd come out and he'd introduce the show, and he'd have like, you know, the library in the background, and
so you want me to pretend? You want me to pretend to be an English guy?
Yeah, an old English guy. Try this on. Look, you got a little scarf there. Here, let's try some glasses. Look a little bit more distinguished.
I don't know how to put this thing on.
Oh, you got to kind of wrap it around your neck and put it through the middle, kind of like a Formula One driver from the '60s. Oh yeah, sweet. Mm-hmm. All right. Oh, now you look totally English.
Now you need me to talk with an English accent?
Like '60s hipster English, but it is still English in some form, in some bizarre form. Masterpiece Theater. See, it's like surgical theater. You get the connection?
If I don't like it, you're gonna have to chop this.
Okay,
out.
Cool. All right.
Welcome to the first episode of Surgical Theater. Today, I'm going to bring you into the operating room and I'm going to show you step by step the details of an ACL reconstruction of the knee. I think this is dumb. Can we just, yeah.
All right, come on.
Can we, yeah. Just,
all right.
Just don't use this. I don't want you to use this.
Oh, don't worry, I won't.
Okay?
I won't.
In today's episode, I'm going to bring you into the operating room and we're going to go over the details step by step of an ACL reconstruction of the knee. This is a surgery that is done when someone injures a ligament in the knee called the ACL or Anterior Cruciate Ligament. So without any further ado, let's go to the operating room so I can show you how the surgery is done. Here's a setup. This is a model of a right knee. When we are doing an ACL reconstruction, in this case, we're taking tissue from the patient and putting it into the patient. So we're making an ACL out of it. You can use several different types of grafts to do this. In this video, we're going to be using the quadriceps tendon. To understand what that means, this knee model is showing you the basic ingredients. So we have the kneecap here, and then we have the quadriceps tendon. In this case, it's only representing the center of it. The actual quadriceps tendon is much bigger and attaches on this side. On this side, this is just showing you the center. And the kneecap attaches to this, and this is called the patella tendon. Down below, some will take the patella tendon graft. This is not the only way to do an ACL reconstruction. This is a way. So when we are watching the first part of this video, you're going to see me make a small incision just above the kneecap, and I'm going to take a small strip that's rectangular of the quadriceps tendon, and then I'm going to prepare it on a table, and you're going to see me pass some stitches through one end, and on that end, I'm going to attach it to a small metal rectangular button. You're going to see me prepare both ends with stitches so that the stitches will hold on to the graft and allow us to provide some tension to put it in place with the right amount of tension at the end of the surgery. So this is a right knee that we're operating on, and you see I'm making an incision at the very top of the right knee, just right above where the kneecap is. So here I am. After lifting up the skin, I'm making a small rectangular slit in the quadriceps muscle. Right, we try to do these through a small incision. And so that's why I'm using these retractors to keep it small. And I've pre-thought out how much tissue I need. You know, we try to reconstruct about 50 to 80% of what the normal ACL thickness is.
So what are you removing here?
So this is a bit of the quadriceps tendon. Remember, the quad has 4 muscles. And where I am is what's called the rectus femoris. It's the center part. And sometimes it's the lower part called the vastus intermedius. And then we have what's called the coalescence of the vastus medialis and the vastus lateralis. They all go together to form this quad. And we're taking a small center strip.
But the tendon is connected to the
kneecap.
The kneecap, okay.
It's a little small strip, right? So if you notice, you see how I'm slowly dissecting around it. I just want to make sure I have just the right amount because there's a lot of variation to how everyone's quadriceps is shaped.
I'm just curious, doesn't this make the quadricep weaker because you're cutting out the tendon?
Anytime you take tissue from you, there is a temporary weakness, and even in the long run, there may be some slight weakness, but it doesn't tend to really impact performance in the long run. So we do these in very high-level athletes as well.
Does it grow back?
There's tissue that does grow back, but you won't get exactly what you lost.
So it's kind of like scar tissue, or what is it?
You get scarring, but we sew this together, but ultimately this part doesn't grow back, but it's a small amount. It doesn't seem to really have a substantially detrimental impact on overall function.
So you can still do your power squats.
Still do the power squats.
Right.
There are different grafts you can take as well too. This surgery is just demonstrating a quadriceps tendon. You see I've measured it before I was measuring it, and I'm slowly applying, this is a harvester. And what this allows me to do is to basically remove this from the knee. If you're gonna notice, I'm gonna slowly make turns, and this wraps around the graft, and it allows me to slowly core it out. And you notice I'm turning, and what this is doing is it's slowly cutting its way through. Do you see that?
Yeah, so it's cutting like a cylinder out of it?
Correct. It's making it somewhat cylindrical, squeezing it there. And now there's a measuring gauge. If you notice, there's a clear tube, and now I'm basically pulling the graft through the middle of this tube. And now I've measured how much I want, and I can pull this up against the tube.
What's that guy doing over there? Just hanging out, sitting? What is that guy doing?
That's the anesthesiologist.
Oh, okay, all right.
He's monitoring the patient.
So make sure that he doesn't wake up.
That's right. You see, I've just cut it.
Ooh.
Cuts the graft right at the top, so I've taken a little strip.
Right.
So here I'm preparing this graft, and so I took what you just saw, and there is a small sleeve on which is attached a little strip of tape. And what I'm gonna do is I'm gonna now sew that strip of tape onto each end of the graft. The graft in this case is the strip of quad tendon. Does that make sense?
Yeah, the tape is for...
The tape allows me, with this needle, to pass through there, and it gives me a little extra tissue.
Like a backing.
It's a backing on which I can sew this graft to. Because ultimately we're going to be pulling on both ends. Remember, I'm going to be inserting this into the knee, and I'm going to be pulling on both ends fairly vigorously. And this construct, we call it, it has to withstand the forces of all the stuff we do in our daily activities.
Right.
Somebody after surgery is going to be moving their knee, they're going to be doing therapy, they're going to be trying to move the knee back and forth. So when I'm applying these sutures, I'm being very, very cautious to make sure that I'm getting a good grip in the tissue and really, really good knots and good tension. And so what my assistant is doing is help moving that clamp. If you notice, there's a little black envelope, and in that envelope, there is a loop of tissue on which is a suspensory fixation device, which basically means we're going to pass it through both ends, and on there...
Wait, by black envelope, you don't mean that big one that's by the guy's hand, but you mean the one that's on the end of the graft, right?
The one that's on the end of the graft.
Okay, yeah,
I'm going to use the other one. So we have one black envelope for each end of the graft. And in each of those, there's going to be a little loop. And on the loop, we're going to have on one end a small little metal button, on the other end a bigger metal button that will essentially use to suspend it to the femur and the tibia, which is going to be inside the knee, which I'm going to be showing you.
So this envelope and this tape just stays in there forever, or does it break down?
No, the envelope I'm going to be taking out. The envelope is just holding on to the loop, but it's just a nice way to do this and keep everything organized.
So that's not going to remain in the body?
No. You're going to see.
The tape stays though, right?
Yep, so watch. I'm taking this off. Yes, the tape stays. The tape is contained within the envelope.
Okay.
And now I'm attaching it back to our graft station is what that's called. And you see now I'm going to prepare the other end. So I'm clamping it and I'm holding on to it.
Do you always do this, or do you have an assistant do this?
I often have an assistant do this.
Okay. So you're doing it now just for our sake?
Correct.
Okay.
Well, I happen to be doing it this day.
Right.
Now, ultimately, we have to be comfortable with all the steps.
Okay, so you're not just showing off.
So,
why is it that your hands look like hands with gloves and other guys' hands look like they're really super thick, like a robot or a fake hand?
Well, he's definitely not, he doesn't have fake hands, but we have different colors of gloves. These are the colors I prefer, you know. Just like pro athletes like things to feel a certain way, I think surgeons, there are certain types of gloves that we like that can give us the kind of sensation that we want.
So yours is a little bit thinner, I'm assuming.
It's a little thinner, a little more
Yeah.
flexible.
Right, you can see that visually. Yeah.
And we double glove, so that I have 2 gloves on.
Right. Why is that?
That's just protection.
From puncture?
It's also, if there's ever a puncture, then I have a separate layer.
Right.
It's for the patient and my own protection.
Okay.
It's a pretty standard procedure. So look, what I'm doing is I'm taking some loops through and I'm passing this around, just like I did in the other end. We pass several loops around and through the graft. Once the graft is prepared, we then want to look inside the knee and assess all 3 compartments. That's the kneecap compartment, the medial compartment on the inside, the lateral compartment on the outside. So you will see me making a small incision at the side of the knee, and we put in a camera called an arthroscope, and then we will first look up at the kneecap joint. I'm going to move this out of the way for purposes of our discussion, and then I'll look at the inside compartment, and we'll look at the femur, the tibia, and the meniscus in between. So we'll look at the cartilage, and we will treat those if needed. Then we look on the outside, the femur and the tibia cartilage, and then the meniscus on the outside, and address those if needed, meaning we fix them if we need to fix them. Then we will look at the notch and clarify the amount of damage we see to the ACL. So the point of doing this surgery is to do what's called an anatomic reconstruction. That means we want to put it anatomically where it was before. So I will mark out where I think the ideal location is on the femur bone, and then we mark out where we think it's going to be in the tibia bone, because ultimately we're going to be drilling before we put the ACL graft in. So I'm putting the arthroscope in, and as I'm putting it in my left hand is the inflow, so water's going in through the inflow. You see it? You saw a little squirt of water?
Yeah.
And the first tube is the outflow, and you see I'm looking at the monitor, and I'm making sure that my outflow is in the ideal location. I'm adjusting as we need to.
So you just constantly have this fluid just rushing through there.
So the fluid is at a very defined pressure, and here is what the inside of the knee looks like. That's the kneecap above. And so I'll come down to the side.
What's that?
And that is the outside of the knee. This is a right knee.
Huh.
And that is called the lateral gutter. So we're in the gutter right now. That's the medial gutter where we're at right now.
And this is where?
This is the right knee. This
Under
is the side of the
knee,
kneecap.
Kappa, or?
The side of the kneecap.
Side of the kneecap, okay. And all that stuff floating around like it's underwater is because the fluid is running through.
That's called synovium, yeah, and it's very fluffy anyway. And this is the medial meniscus. We talked about the meniscus in the last episode, but that's the medial meniscus. That's the normal meniscus. That's the cartilage on the top. That's the femur and the tibia on the bottom. And you see, it looks like a shiny, smooth ice skating rink. And now that's that synovium. And so...
This, the fluffy yellow stuff is the synovium?
Yeah, that's called synovium.
And what is that?
And the synovium are cells inside the knee that actually produce joint fluid.
Oh, okay.
They have a lot of nerves in them as well, too.
The meniscus is right in the middle.
It's right in the middle. So remember, the meniscus is a triangular wedge.
Okay, so the meniscus is kind of white, silver, that thing right
That's
there.
it. See, I'm going above and below it.
Okay.
So I'm looking for tears. And you see I'm looking all around. It goes from one side to the other. And that area in the back is where it's connected. You see what I'm pulling on? That's called the root. You notice it's not going anywhere.
Right.
And in the very back there, sometimes there's a tear that people can get that will often be missed if the surgeon doesn't look there. So always look there. If you notice, all that fluffy stuff is in front of my face.
So what if there is a tear?
Well, then we fix it.
Right away, right there?
Correct, right
there. So you
there.
get a 2 for 1? 2 for 1 special?
Sure. Look, that's the lateral meniscus there. That's the root of the lateral meniscus.
So I didn't know that. So you guys fix the meniscus too while you're doing the surgery?
Absolutely. We do it all right there. That's the whole purpose of doing it, is to do anything arthroscopic we have to do right there.
There you go. That's efficiency.
And so you see, there is the lateral meniscus, the outside meniscus. That's the back root of it. It has a slightly different shape.
I keep feeling like I'm watching some kind of documentary on a mollusk or something.
As you watch the very underside of that lateral meniscus, there's a very small crack on the bottom. I'm going to point at it with my probe right there. See that little crack right there? Just to the left of my probe, right there, see? It's a small partial crack.
You mean a tear?
It's a small little tear.
Right.
We don't have to do anything about it because if you notice, it's not doing anything to the meniscus. And that hole you see right there, that gap, there should be an ACL there. That lump of tissue to the right of that, that's the ACL.
So just completely just pulled out of that
It's
hole.
completely pulled off. Yeah, there's the torn ACL. If you notice, there's scarring around it. It's stuck to the roof a little bit. And to the right of that is the PCL. Looks like a bit of an X. You see how there's a bit of an X? One side of the X is what I'm on. If you look, there's another X that's very fluffy on the other side. That's the PCL. And so this device here, if there is some bleeding, it has a little bit of heat at the tip, and it will allow me to help stop bleeding inside the knee.
Why is that tube glowing?
Because that's fiber optic. It's a fiber optic tube.
Oh, for the camera.
Correct. That's going to the
okay.
camera.
I thought you guys were just doing like a little bit of a rave thing there, a little touch.
Well, no. So that's the ACL stump that we see here. And so I'm cleaning up the attachment of where it used to be.
Right.
And so you see what I'm doing is
By ACL stump, you mean it's the leftover part after it ripped out?
Correct.
Okay.
So it's attached on the tibia, and here I am, I'm cleaning up all the stuff that's going to get in the way, because for this operation to go, ideally, I want to be able to see where it attaches to on the femur, and I want to see where it attaches to on the tibia.
But it disconnected from the femur, you're saying?
Disconnected from the femur.
But still attached to the tibia?
Still attached to the tibia, but
Okay.
there are different tear patterns, so it can tear in different locations. I've cleaned it up enough, and you see every once in a while there's a little bit of blood that comes down over here too, and sometimes I'll just stop and let the fluid pressure increase, because on the shaver that I have, there's a suction. That's why there's a...
Oh, so it's sucking in that material.
That's right. I've cleaned up the wall, which is that bone to the left, right? And so now I'm taking this sharp tool, it's called an awl, and what I've done is I've decided where I want to put this femoral tunnel, and what I'm going to do to be as precise as possible is I'm going to tap this in just a little bit,
Yeah.
and by tapping it I'm going to get a mark, and that little droplet was marrow droplets.
The yellow drop that came out,
Yep.
right? It looks like oil, kind of.
Exactly. And I take this arthroscopic ruler, and you can see I've taken that little mark and I've used the ruler to measure exactly where I want it to be. In this section, I'm going to actually make a tunnel, which means we make a little incision on the side of the knee, and then we're going to drill from this side right through the center, and you're going to see me put a small pin on the inside of the tibia. And then what we're going to do is we bring in an X-ray machine called a fluoroscope, and we want to confirm that that pin is in the ideal location. Then I'll slowly drill the tunnel with gradually increasing sizes so I can get just the right shape and size and position that we need on the inside part of this tibial tunnel. So I'm getting ready to place the tibial tunnel now.
What's the anesthesiologist looking at in his hand?
Probably checking his phone.
Yeah, that's what I thought.
Well, I'm entering into the joint. This is a tip guide, and basically the pin I'm going to drill is going to come out right where that tip ends. Here, my assistant is handing me the drill.
So you're drilling a hole through the tibia? And
Drilling a hole through the tibia.
that marks where it comes out.
That's right. That marks exactly where it comes out. This is what it looks like arthroscopically. I'm going to drill right on the inside, and you'll see that drill come out right where the tip of my guide is, right at the tibial insertion of the ACL. And I'm going to push on that so it'll come right at the other end of it. There it goes. So it's right at the other end of the tip.
Okay.
Right through the ACL. So now I'm right in the middle of the stump, which is what we want.
So how big is that hole? Like diameter-wise?
Well, right now this is about 2 millimeters.
Okay, so it's smaller than it seems.
It's very small.
Right.
But now watch, just so I can be really sure that it's in an ideal location, I'm going to bring this portable X-ray machine, and I'm going to lay it on top, and what I want to do is to look at it and make sure it's in the most ideal location it can be in, right at the front to middle part of the bone.
Right, because you want the movement to be, the best location for unimpeded movement and...
Well, sometimes the shape of the knee can cause the bone to pinch into the graft, and I'm looking at this. If you notice, I'm looking at it, I'm looking back and forth, and we adjust this. And once I was satisfied, then we pull the machine back. If I'm not, I'll actually reposition the pin. Now here I'm coming back into the knee, and so we're back in the knee, there it is again.
So when you say reposition the pin, you mean re-drill the hole?
I would, if I wasn't satisfied. The good news, it's very, very unusual when we have to do that.
So when you re-drill the hole, does that all heal up like the old hole?
Oh yeah, well if you notice what we're about to do now, is I'm going to make this hole a lot wider. Because the graft we have is about a 10 millimeter. and this is, I said, only about 2 millimeters.
Right.
Right? So now I have to make that wider. So again, you can just go from here straight to a 10, but because I want to be as precise as possible, and because the ACL is a little more oval shaped, then what I'm going to do is I'm going to start off really small, and I'm going to take a drill that is about double that size, so around 4.5 millimeters, and I'm going to slowly go from smaller to bigger. But as I'm doing this, I'm watching this, and I'm positioning the pin so I'm right in the middle of the ACL. If you look, I'm right in the middle.
Yeah.
But you see how it's a little bit wider now. So it's about double the size. But if you notice as I'm doing this, I'm kind of going back and forth a little bit. I'm pulling it forward, I'm pulling it backwards, because I want to sit right in the footprint, is what it's called. I want to sit right in the footprint of the ACL.
Okay.
Because if I do that, then I have the best chance of putting this in the most ideal position.
Right. Well, the most ideal position being the original position.
Correct, the position it was in. Because
Yeah.
everybody's shaped a little bit differently. Sometimes this hole will be bigger, sometimes it's going to be smaller. I'll pick a graft of a different size for a larger person. I'll pick a graft of a smaller size for a shorter, smaller person.
So the final hole's, like you said, 10 millimeters, the final hole?
10 millimeters,
So that's
we
like,
want to be able to fit in a graft that's 10 millimeters, yes.
Yeah, that's less than half an inch. That's like,
Yeah.
what is that? Yeah.
So here I am, and so sometimes there's a little bit of this tissue debris, so that's bony debris. See, if it gets a little bit looser, so if you notice I'm clamping onto it at the top.
Right.
I'm clamping onto it so when I pull back, it doesn't pull the pin out. But you notice there, see, I'm just trying to get...
But it's spinning and you're clamping onto it.
The pin is not spinning.
It's stationary and that spins around the pin.
Correct.
I see. Okay.
But if I pulled back and I wasn't holding onto it, then the pin would come out.
So I'm curious, I know this is a strange question, but what would a drill like that cost?
That's a good question. I have no idea.
Really?
I have no idea.
That'd be interesting to know.
There are very few medical devices that are inexpensive. That's the problem.
Yeah, I would assume.
Yeah.
It's not something you can go to Home Depot and pick up.
Correct.
Right.
There's been a lot of R&D that goes into many of these devices, and so they've been around for a long, long time. And so I think those are all the things that lend themselves to the very elevated cost.
Yeah. Yeah. It's
So
highly special.
we'll clean it up just a little, and just make sure I'm satisfied with it.
What are you cleaning up now? Just the stuff around the hole? The
Correct.
opening?
Because one of the concerns is if you drill the tunnel and you leave all that debris there, that debris itself can cause scarring that can later lead to pinching of the front tissues.
Why not just cut out the whole thing?
You can. There's some evidence that having the tissue there may be biologically favorable, and I think this is a interesting future avenue as far as how much of that should we leave. There are surgeries that are available now that we can actually repair the ACL too versus reconstruct. And that may be a topic for future videos. But see, at the very front, see I'm cleaning that at the very front. When you straighten out your knee, if we leave too much tissue there, that can sometimes cause what's called a cyclops lesion, where you get a big bunch of scar and it pinches in the very front. And sometimes even when you clean this out perfectly, you can still get scarring in the front. But every ACL surgery, I try to clean it out in the front so that there's nothing really pinching when all is said and done. We'll be able to look at it when we're all done here as well too.
Right.
Now we look at the femur part of the ACL reconstruction. And so in this surgery, I actually use a special jig that wraps around this so we can drill from outside in. And then there's a device that actually, like a helicopter, will start to rotate, and then we can drill a tunnel the size that we choose from inside to outside. And we basically make that about 2 centimeters, a little bit less than an inch. And once that's done, we've completed the preparation of the femur tunnel. So now we're going to start preparing the femoral side. And here I am taking this jig. I've gone through a small incision. And now here, this has got kind of a question mark shape almost. And so this is 9 millimeters wide from the tip of that metal to the tip of that metal. So if you remember that hole I made previously,
Right.
I made that hole where I thought it needed to be. And now I'm
This is the femur side.
the femur side.
Right.
This is the lateral femoral condyle is what it's called. And that guide has some spikes on it. So I'm affixing it around where I think the pin is going to come out. And I want that pin to come out near where my hole is, the one I made with the awl earlier in the surgery. So this allows me to quality control that step.
Yeah.
So now from the outside, this is the outside of the knee. And so I'm making a small incision. And what I'm going to do is I'm making a small incision on the side of the thigh. And I'm going to push this jig down onto the bone. I'm going to drill this pin right down the center.
Through the femur.
Through the femur, and I'm going to look at it from the arthroscopic end. What we're hoping to do is to get that, as close as we can to where that hole was that I applied before.
Right.
If I can get it close to the hole, that means I'm going to be where we need to be. And you'll see a little rumble and some tissue come out as the pin gets closer.
Okay, we're approaching the moment of truth.
Yeah.
Did he get the hole?
Yeah. And as you can see, it's coming right out of the hole, so it means I'm really close.
Wow, look at that.
Yeah.
That's pretty good.
Yeah, so it's right in the middle.
Yeah, congratulations.
Yeah.
And that is bone matter. That white stuff is bone matter.
Yeah, surgeons get very good at using technology, right?
So wait, if we didn't have that fluid running through right now, this would just be just a ton of blood right now, right?
It would be a ton of blood. It would be very, very difficult to see. So what this allows us is we use our fiber optic technology to be able to see all these things very clearly and do these very highly technical surgeries through very small instruments. As you saw, these instruments are not very big. The incisions we're making are not very big. And so now we look at it again, and remember, for me specifically, I like to audit every step. So when we look at it, I measure it a bunch of different ways. And now I want a slightly bigger, it's called a reamer. This is different than the other one because we're going to be going and pulling back on this. What's unique about this drill pin is once it goes through, I can set it to whatever size tunnel I want. I'm going to set it to a 10, but what you're going to see it's going to do, it's going to bend the tip of the drill. So as this comes through that same hole which I was at before.
This is more marrow coming out, right?
More marrow coming out.
Oil,
See, this is
oily looking stuff. This white stuff is just
this is more bone. This is a wider pin that I'm putting in. And so now I have this in the right spot. I'm going to remove the jig, and then I'm going to double check once the jig is out. You see with my finger, I'm setting it to a 10, and so that just sets the radius. And then the diameter is going to ultimately be a 10. And if you notice, it bent and this little thing came out, which is like a rotor almost, like a little bit of a helicopter
that little thing
rotor.
At the end.
You see that?
So you're pulling it in through the hole to
while it's spinning, while the helicopter's spinning basically.
Going backwards.
But I'm going to have an assistant protecting the tissue that's to the right, and I'm now just auditing it with my hand and making sure that when it is pulling back, that it's still going to give me the tunnel right where I wanted it. So again, I'm always double checking and triple checking.
So what's that big cavity that we see, like right in the middle behind all that?
Behind all that is just the back of the knee.
That's it.
I've cleaned it up. Yep,
that's the back of the knee.
The back of the knee. So where I'm drilling is where the native ACL previously attached.
Oh wow. Okay.
So here I am. I'm just auditing this and making sure that's okay. And
so how hard is it to drill through bone?
It's pretty hard. That's why when we drill this, you're going to see I'm going to get it to start moving, and then I'm going to pull back.
Right. So is it like wood, or is it worse?
It depends. Interestingly enough, people with very hard bone cell density is harder. And you see what I'm doing right now creates more bone debris, and I'm pulling back just about 2 centimeters because we're making a small closed tunnel, right? And remember, I've drilled a pin through, and we have a tunnel through, and here I am. Look, this is what it looks like from the outside. I'm pulling back. And if you notice right where my right index and thumb, there is a ruler right on that long metal pin, and I'm measuring how far back I'm pulling it.
So I'm curious, how hard is it, like compared to what material? Like what would it be like?
What's interesting is there are people who have very, very poor bone, and it's very soft.
Like
sometimes
pine?
It can be buttery. Sometimes it can be buttery, but there are some people who...
When we say soft, what do you mean? Like soft like pine, or like...
pulling maybe about, imagine if you lifted about 2 pounds.
Right.
About that hard.
Really?
If you want to pull on it, yeah.
Oh, wow. And then
sometimes it's very easy, and some people it's like 10 or 15 pounds.
So
where the bone is very hard.
Like drilling through what?
Like drilling through wood.
Like, okay, it's like a hardwood.
Yes, exactly.
Oh, wow, okay. So it really depends on age, I'm assuming? And...
Well, actually, it depends on activities as well, too. So now if you look, here's the hole I drilled. If you notice, you can see that there's bone all around it, which I check. And I'm pulling out the device I applied, and I'm applying this red tube. So now the whole point of it is to pass the graft from the tibia into the femur, right?
Right.
And so now I'm placing the femur part of that. So this is a loop. And what I'll be doing is placing the stitches I initially applied through that loop.
So you can pull it up through the femur.
Correct. But you notice I just passed it from the outside of the body into the femur, and now I'm going from the outside through the tibia, and I'm grabbing that loop. You see that?
It's like a little noose just to grab it and so
it's
you can
a
pull
noose,
it up.
correct. So now that the tunnels have been prepared, we are ready to put the graft in. So what you're going to see is that we're going to now take that graft I initially prepared with the stitches on both ends. There's a button at the tip, and we're going to bring that button all the way through the tibial tunnel, into the knee, through the femur tunnel, and that button is rectangular. So when we pull it out, we're then going to flip it so that when we pull back down it now attaches almost like something that a mountain climber might use. So a little rectangular button, and when we flip it, it now attaches and connects right to the outside part of the knee. And then I'll usually bring in that same machine called a fluoroscope, and we'll check and we'll make sure it's sitting exactly where we put it. And then we'll actually pull the graft up into place and make sure it is seated well in the femur tunnel and it's seated well in the tibia tunnel. And then we'll apply some tension on it. And then we'll actually cycle the knee several times, meaning I'll move the knee back and forth to make sure it is appropriately stretched before we apply any other fixation. And then I'll put a little round button at the end over here to tighten it. And we'll sometimes back that up. And then once we do that, I'll come back and check that the graft is stable, and that basically completes the surgery. So I'm going back now, and I'm just quality checking everything too. I'm making a little purple mark. I always like to measure multiple times before we put these in, just to make sure everything adds up. You know,
yeah, exactly. It's like woodworking, right?
It's very precise. And
measure 3 times, cut once.
Exactly.
Right.
Because remember, I made all these tunnels, and I'm making sure are all the numbers still adding up. So I'm making sure it's fitting through. That's called a sizing tube. And so now that same noose, you called it, the loop that I passed through. Look, I'm putting the stitches from the very top on there.
Yeah.
And I'm pulling it all the way out the very top end.
Yeah.
All the sutures are out. You see that?
Yeah.
Now on the sutures, remember at the very beginning, I prepared this very small button. That little thin button is going to flow through the small holes. Look at the small hole I made at the top. Remember, I made a wide tunnel and a small hole, right? So here I am, I'm looking at the button. See that little thin button that's metal?
The button's only 2 millimeters wide?
The button is about 3 millimeters wide.
Oh, okay.
Right? And so I'm going to pull it up. If you notice, I'm pulling it up through.
So wait, what are we looking at? That flat, is that the inside of the bone?
The flat part is the outside of the bone. That's where when I was tunneling, that's where I ended.
Oh,
so now I've pulled it out, and now I can pull on both ends of the stitches or on different sides of the metal button, and it will now make it perpendicular. So before it was parallel to the hole, now it's perpendicular, and I'm going to pull back. In my hand, I'm pulling back, and I'm seeing that is where I think it needs to be. But again, remember, I like to double, triple check everything.
Right.
So I'm going to now take this portable X-ray machine.
And that red tunnel was literally the inside of the femur.
That's the inside of the femur. I went in the tunnel.
You're actually looking through the tunnel.
That's the tunnel. I'm looking through the tunnel.
Okay.
And so now I just checked it on the X-ray machine, and I confirmed that the button was sitting exactly where I wanted it to be. So now what we're doing is we're tightening it up. The loop that initially applied has a special kind of a mechanism where as you pull on it, it'll pull the whole graft into place. And you can see now, as we're pulling on it, that's what's happening. Remember that purple mark I made?
There goes the graft, yeah.
And there's the graft right there.
Yep, going
you
up
see I'm
into
docking
the
it.
femur.
Yep, and I've marked it right about 2 centimeters. That's how much I want. If you notice, it's sitting very nicely right now. So you see the femur side has been docked.
It's very flossy looking.
Yeah, it's very shiny.
Shiny and flossy, yeah.
Well, this is tendon. Remember, that's
almost
tendon.
like a fishing line.
Well, it's
very
tendon.
shiny,
It's a tendon of the quadriceps.
Oh.
Yeah, the body is very, very well designed, and over time, that's going to slowly become a ligament. This is called ligamentization. If you notice, all the cleaning that I did becomes apparent now because you can see very clearly the top and the bottom. And now I'm moving it just to make sure everything looks good. A little bit of blood as we're moving it around as well too.
This is coming from inside the femur, the blood?
It's coming from inside the bone tunnels because bone has got a very robust blood supply.
Yes.
And so now that's the other end of the loop. And now I do what's called cycling the knee. And there's evidence.
So this is not the patient doing this, of course.
No, that's me. And I cycle it about 40 times to make sure we loosen up the graft just enough. And now what we do then is we apply the second button. So if you notice, the button was applied right there. It's a little bit shiny here, but the button fits right in the middle of that loop. My assistants are helping to secure the knee so that button goes right down.
Yeah, and it stays on the bone. It's like those little bungee cords that have the 2 little flat metal things on the end. You push it through, and then it goes
more or less
perpendicular and holds it in place.
More or less. So I've tightened it on both ends now. So look, we're secured on the tibia and the femur, and this is called the backup fixation. This is called an internal brace.
Wait, what's that for?
An internal brace is just extra protection. You know, this is
What actually is an internal brace?
an option, but it's like a seat belt in a car. When the seatbelt is on in the car, it's nice and loose. And what you hope is that if you get into a situation where you have a lot of stress on the car, that the seatbelt will protect you.
So the internal brace is connected to what?
So the internal brace is connected to that very top button. And so what I'm doing is I'm applying it a little loose. I have an assistant who's holding it under some slack. I'm tightening the femur side and the tibia side. I've let down the tourniquet. If you notice, it's actually some.
Yeah, all right. It's all,
Right, so I'm now tightening the femur and the tibia side. The internal brace is just a way with the seatbelt mechanism to apply it a little loose so that as the normal forces of daily life are on the graft itself, that the brace will help protect
But
the ACL
what
graft.
actually is the internal brace?
It's a small piece of polyester tape.
Okay, just a small piece of tape.
If you noticed
And it goes across the graft.
it goes from the top to the bottom,
Right.
but it's independently fixed.
Right,
separately.
okay, I see. So how long is this going to take to heal?
So the process of ACL healing, interestingly, is in different stages. So the first stage is the body will react to it, this
Right.
inflammatory stage.
Yeah.
Then the second stage is there is a lot of repair tissue that is laid down. And the third stage is it gradually remodels. So all in all, probably takes anywhere from a few months
Right.
up to a year
Wow.
to fully remodel.
How
But
long is the painful part, the worst part of it?
the worst part is probably the first few days.
First few days, and
Yeah.
then it's much easier after that?
Yeah.
Okay.
Thank you for watching this episode, the first episode of Surgical Theater. We reviewed step by step the details of how to do an ACL reconstruction of the knee. How did that go? Do you feel like I covered all the main bases? Do you feel like that was
me. I loved it.
Was that understandable?
I thought so. I mean, people can always watch the video again.
The point of it is to make it simple, understandable, hopefully not gross,
Right?
right? Stay tuned. There are going to be future videos specifically going into the operating room, going over step by step details of these operations.
So what's the next one in the series?
Most likely how to fix someone with a dislocating shoulder, but we'll have you stay tuned for that one. And if anyone has any questions or comments, leave them in the comments box and I'll do my best to respond to those.
And everyone, make sure to subscribe.
Can you do it like a James Earl Jones voice?
Does my voice sound like it goes that deep?